Well, good afternoon. I'm going to go ahead and get started and introduce my colleagues from infectious diseases, infection control, and infection prevention. Thank you, Mary Ottolini and her team. They have given patient safety quality improvement, I believe, 2 or 3 grand rounds. 4 grand rounds. Well, I thought I was magnanimous because we wanted this one to be completely dedicated to infection control, infection prevention as we kick off the new year. When we look at the contribution of the team, it's pretty spectacular. We've had an 80% decrease in urinary tract infections year over year. Those are catheter associated. A 35% decrease in CLABSI while maintaining a 95% hand hygiene rate. This group is fascinating, and I know about it because I have the pleasure of working with them at all hours. They deal with measles outbreaks, Ebola rule-out patients, a case of rabies at one of the satellite clinics. Don't worry, everything's good. That was a while ago. But just the span of what they impact is truly extraordinary. And I really think our success for quality is really attributable to the strong team we have. So, Roberta, thank you. I know we've built up the cohort. I was trying to count how many we have, but I don't really know. We have a big, big cohort. I'd probably say about a dozen people committed to the infection control, infection prevention. So I acknowledge that. We have 4 people to introduce. It's going to be interactive. pollev.com/mottolin. That's Mary Ottolini, obviously, but it's her way to get in. And you'll answer throughout this discussion. It's probably about 40 minutes grand rounds, and then there are going to be discussion questions to help clarify. So let me introduce them. I'm going to introduce them alphabetically, but Ben will be going first. So Rana Hamdy, I believe her and Netta are the newest additions to our team. Rana comes to us from up north, which isn't too far away. She did the bulk of her training at Hopkins and then went to University of Pennsylvania for clinical epidemiology and biostats. She did her pediatric infectious disease fellowship at CHOP, and we're really lucky to have her down here leading the director of our antimicrobial stewardship program. She's hit the ground running. Many of you have seen some of the preliminary data, which she's going to show us here on how we're an outlier, not in a good way, with antimicrobial, so we look forward to working with you. Ben Hanisch, everybody knows Ben. I think Roberta said he takes the most difficult cases and then figures them out, so we appreciate Ben. Ben works with our immunocompromised patients, those that are transplant recipients. He's been with us since 2014 and did his fellowship at the University of Minnesota. Netta Harik is also one of our newest team members as well. She came to us from Arkansas Children's after doing her fellowship at University of Washington. She was at Arkansas for 10 years, Arkansas Children's, and brings us all that expertise. She's a clinical consultant for the infection control program and the associate director of the fellowship. Finally, we have Dr. Songl, who's a real partner for many of us through the Joint Commission visits, et cetera. Many of you don't know, but she's PhD trained. She's had 18 years of experience in infection control epidemiology. Roberta and I say this all the time. I think the best way to recognize Dr. Songl is she's an international leader and real national leader for infection control and epidemiology. So when we have outbreaks, it gives me great solace to know that you're here to lead us through them. So let's start with this, and I'll turn it over to Ben.
All right, good afternoon, everybody. The title of our talk is "An ounce of prevention is worth a pound of care." Our objectives for this afternoon's talk is to discuss a little bit about healthcare-acquired infection as well as multi-drug resistant organisms, how they are created, how to avoid, and how to manage. As well as to clarify and explain a little bit the services that are offered by infectious diseases service, infection control, as well as antimicrobial stewardship, as well as to provide you some resources that you can use in your day-to-day activities to help us fight the healthcare-associated infections and MDROs. So today I would like to share with you an illustrative case that I hope you'll appreciate. So the case is a 7-year-old boy with intestinal pseudo-obstruction that occurred as a result of NEC, who is admitted for feeding tube displacement, who after a day of admission is found to be highly febrile and unwell appearing. He was empirically started on meropenem, amikacin, and fluconazole, and cultures of the blood and the G-tube site were obtained. So whenever we start to treat an empiric infection, it's important to know what infections the patient has had in the past. For this patient, they have a history of several infections with Klebsiella pneumonia that was initially quite susceptible to our antibiotics, although after multiple infections has become quite resistant and quite difficult to treat. And this is why we this is why the empiric antibiotic regimen was chosen that this patient was on. So despite our empiric antibiotics, this patient did not improve as quickly as we wanted. In fact, they continued to look fairly poor. And cultures from the G-tube site returned that shows increasing resistance in intermediate susceptible to the amikacin, which the patient was on, and resistance to the meropenem that the patient was on. So at this point in time, we changed the patient over to gentamicin. And in cases of suspected bacteremia, treatment with just an aminoglycoside is not a therapy that we're comfortable with, and we investigated alternative therapies. And in this case, it's colistin. Colistin is an antibiotic that we hold in reserve against the multi-drug resistant organisms. Unfortunately, we're having to use it with increased frequency, although we do not standardly test for colistin susceptibility on our isolates right now due to the lack of common need for this. However, our patients came back colistin resistant, which posed both a patient management as well as a concern about what to do with the hospital and what's going on with this. During this time, there were increasing reports of MCR gene mutation, which is a bacterial gene that can be transferred from one bacteria to another bacteria, giving colistin resistance. We did test for this gene in our patient, and fortunately this was not seen, but it is still quite worrisome that we have colistin-resistant isolates in our hospital. So although our patient didn't have the gene, this gene was seen in the United States just a couple months after in Pennsylvania, so not very far away. So this is a continuing threat and something that we need to continue to keep our eyes out for. So to do a care everywhere, just to test out our care everywhere. So let's just put you in our seat. And so we've diagnosed. So we have a culture result that shows that we have a colistin resistant patient, a patient with a colistin resistant isolate, and. What do we do next? Do we call infection control, call infectious diseases, place your patient on isolation, start working on your case report, or A, B, and C? Okay. All right. So a little bit of movement. So the preponderance is A, B, and C, which absolutely right. So this is definitely something that all three of these, that both infection control as well as infectious diseases are needed to help manage and place the patient on isolation while we're figuring out the best next steps. And then while we transition, I wanted to share with you this cartoon. The patient in the next bed is highly contagious. Thank God for these curtains.
Thank you, Dr. Hanisch. Well, I think as Children's National, we can offer not only good curtains, but we can also offer something even better. And this comes our infection prevention and control team, which we call ourselves Germ Busters. So this team, actually, right now we have 60 infection preventions that really sensitive to the hospital's strong leadership support. And I oversee the program's day-to-day operation. And Dr. Harik just joined the institution as infectious disease specialist, and she has a dedicated time to work with me, the team, and we are here as basically the resources for you. Work together to fight against the hospital-acquired infection. So by definition, this hospital-acquired infection or right now, it's in the even broadest spectrum, we call it healthcare-associated infection. It actually refers to the infection that patients develop during the hospitalization and the infection that was not present at the patient's admission and was not even incubating at the patient's admission. So some examples like norovirus that happened to a patient who are here ready for the respiratory distress and happened 10 days after hospitalization. That we will consider norovirus infection as a hospital-acquired infection. A bloodstream infection in a patient with support who are here ready to get the chemotherapy and 4 days later develop a fever and then consider as the bacteremia. At that point, this bloodstream infection is another hospital-acquired infection. RSV infection in a patient admitted for chronic liver disease or renal disease, that's another hospital-acquired infection. Therefore, the HAI can be very broad, and also can be allowed if we're not careful enough. Therefore, for many years, infection prevention and control has been incorporated into many aspects of a hospital's operation. So when you are thinking of rebuilding your space, clinical areas, infection prevention and control team actually behind the scene and work with all the key stakeholders. We want to make sure when the space is up running, you will have access to everything you need to do the infection prevention and control when the space is open. And when the space is actually up and under construction, we are there working with the builder construction team just to make sure air is properly sealed, store the dust. So whoever walking by the area will not necessarily being contaminated. And we also have defined the cleaning and disinfection process. And of course, we are here with every single frontline provider, with every single one of you to prevent the, to prevent the device and the procedure-related infection. Also, we actually work with our engineer and the facility as well as the safety team very closely because we want to make sure the water is safe for everyone to use. So we're here working as a team member to prevent the disease transmission between individuals, and I think you all have seen our participation and involvement 2 years ago when Ebola was present in the States. And so we're also the team that helped to define the staff vaccination requirements. We'll also help to prevent the staff exposure to infectious disease. And once in a while, there will be a whoops moment, such as a sewage pipe burst. And so at that moment, so basically infection control team are part of the frontline responders. We want to make sure this kind of like incident will not cause a secondary threat to everyone's health. So we are here a lot, and you definitely have seen us. And why? Because we do have to work with every single individual that comes to the institution. So that includes our patients, families, visitors, staff, with or without infectious disease, but we're there because we want to make sure they are protected in the sense of they can get good care, but not necessarily have any health threat. And also, environmental safety is another aspect of infection control. We want to make sure the environment is safe for everyone who is in the institution. Of course, we're committed to prevent HAI one at a time. So this is very much in contact with our infectious disease specialists. Of course, the hospital here and for our patients who need medical care. When our patients come to the institution, they are in good hands. And our infectious disease specialists who work with the patient's primary care team, they're there to help diagnose, they help with the treatment, eventually to cure the disease. And oftentimes they work with the individual patient with infectious disease at a time. But coming back to infection prevention and control is really dated back in 1850s when this brilliant man just said 3 words, and he saved the life ever since. The 3 words is wash your hands. And 300 years later, I think is HAI all gone? Not necessarily. So this is the estimate was published by CDC in 2011. As of 2011, HAI still affects 1 in every 25 patients in the U.S. acute care hospitals alone. So what that means? That means every year we'll probably come across nearly 750,000 HAIs nationwide, and we'll have 75 patients could possibly die of HAI. And the healthcare society as a whole, we spend nearly $5 billion for managing all this HAI. So it is still a huge burden to the society and to the patients who are affected by the HAI. So, people will ask, it's like, there has been so much, advances used in so many different aspects. Why we cannot get rid of all those HAIs? I think the first we have to face the fact, HAI are caused by germs, what we call the pathogens or organisms. And these germs, organisms, they are everywhere. And they are not actually, visible to our naked eyes. However, you put on the microscope, we'll see them. So this is a room that's actually occupied by patients with vancomycin and enterococcus. Patient left the room, researchers came in and they did swab of the surfaces, and where this green mark basically indicates, all this mark just indicate where VRE was still there. So if the next patient come in and several of those dots are still left on the surface, the patient is at a risk to get a VRE. So this is actually a very similar study was done barely 3 years ago, and this time this room was occupied by a patient with the carbapenem-resistant Enterobacteriaceae. And so, of course, the 12 surfaces were cultured, and no surprise, the CRE was still there hiding. And the most striking is the payload. 33% of the time, you will find the CRE on the payload that used by a patient. So they are here. Then the question is, all right, so let's see. So they just be on the surface for a minute, and then they're dead. If they're dead, they don't harm anyone. Or if they are there, they really hang there for a month or for days, they have a good time, we don't know. So take a wild guess and tell me, like after all this pathogens or organisms, which one you think they can leave a patient bedside table for more than a month? More than a month. Take a guess, there's some, I will tell you which one. All right, so majority went, oh. All right, so I think a majority wins. Yes, awesome. So, some of those, like especially those gram-next, right now we're really concerned their resistance, carbapenem-resistant, this whole family. Sometimes they can stay there for over 30 months and still alive. So that's the challenge we are facing. And then the question is like, everybody probably like, gosh, what I'm doing, why am I in the hospital where, we'll probably come across the germs everywhere? Am I in trouble? So the answer is no. You and your patients are protected because as an institution, we are really obligated to provide everything you need to make sure your health is safe and sound when you work in this hospital. And so that's our protection goes on to our patients. So you probably have seen the purple wipes. We used to call purple wipes because that lid comes with the purple lid, and that's what we call the germicidal wipe. Now we're switching to this white lid but purple label, and this is another type of a germicidal wipe. And so when you have moments, you see this, it's for everyone. Just wipe your phone, wipe your stethoscope, wipe your pager, and so it will help to keep the germ free. And those isolation gowns, what we call the personal protective gears, they really serve as a physical barrier between you and the germ on the surface. To use it was indicated, last but not least, your hands will be contaminated. So the question is, you got to wash them away with soap and water, or you can kill them with the sanitizer. So that's the whole reason throughout the entire institution, you will see all this being loaded in the hospital because we want to make sure your health is protected. Your health is the first priority to everyone. So, but that we also want to say, well, in our mind is what happens in the environment is stay in the environment. And we have a little study done that was done like about 3 years ago in our own neonatal intensive care unit. So in this study basically shows when staff hand hygiene compliance rates go above beyond 80%, it is associated with a 48% reduction of MRSA acquisition in one unit. What that means? It means it will help to prevent 1.3 MRSA acquisition in the unit a month. It means it's going to avoid almost 12 days ICU stay in a month. It's going to help someone to save nearly $70,000 a month. So it's quite, and also besides the germs, besides the MRSA, besides this, we also have I think after 300 years of progress, infection prevention and control has really become an evidence-based practice. There has been ample of the data study published to confirm, and basically, if we follow best practice, it's going to prevent HEIs. For this, HEIs include the central line associated bloodstream infections. What matters? The type of catheter you choose, where this catheter was placed, and how it was placed. And of course, every day today, when you draw the blood from the central line, when we actually give medication through the central line, every single time we touch the line, access the line, it makes a difference. Catheter-associated urinary tract infections, summer rule is if we don't have urinary catheter, we don't have urinary catheter-associated infections. But we understand from time to time there will be patients who must have a urinary catheter. In that case, insertion technique will make a difference to the patient, and so is the maintenance. Last but not least, the surgical site infections. So there's many different ways to prevent, but one of the fundamental preventive measures is the proper antibiotic prophylaxis timing, agent, dosing, and sometimes the redosing. So this chart shows another success story in this institution. And this back in 2005, our infection rate was this much. And after 5 years, the team's commitment and committed to practice evidence-based practice. In 5 years period, we were able to reduce the Class C by 89%. What that means? That means that we actually able to prevent 241 infections. We're able to save 48 lives, and we actually helped the hospital to avoid $17 to $70 million money. And this was the payer. It could be insurance paying for it. It could be paid for out of someone's pocket. But if the insurance figures this infection required under your care, you have to take care of it. That means the hospital will have to pay this much money. So the upside of being success, yes, there will be times things don't go right and go to the wrong way. So we will say our colleagues and our neighboring hospital on the headline in the big news, and I don't think anyone of us, that's kind of a position anyone of us who wants to be associated with. It's attention I don't want to be drawn to this institution at all. And so, and also, that will be tragedy. So this is a hospital where they were able to treat 5 deaths to a contaminant. And look at those beautiful boys beyond life. You know, they were able to fight after transplant. They were able to fight for their severe immunity disease, but they lost life because the linen they were provided while they are receiving care in this hospital. So I think, you know, also look at this beautiful family lost our beautiful boy, not because the transplant, not because the disease. It's because a bug that was harboring in the hospital. So with this, looking at all this, I always want to ask myself, you know, my team all over and over is, can we do more? Can we do better? Because in my heart is really infection prevention takes village. So next it's my privilege to introduce that.
Thank you, Dr. Thank you. So Dr. Song talked about the important role that infection control and prevention has in preventing the spread of a multi-drug resistant organism from one patient to another. And I wanted to talk to you about what we as a community can do to prevent the emergence of an antibiotic resistant organism to begin with. So antibiotics were first discovered in the 1930s. And as you can see from this timeline of antibiotic resistance, it really doesn't take long from time of deployment of a new discovered antibiotic to when we start to observe resistance to that antibiotic in the community. And bacteria have become resistant to every single antibiotic that has ever been discovered, every antibiotic that we have in our arsenal. And we know that the #1 driving factor that leads to antibiotic resistance is use of antibiotics, use of that particular antibiotic. And that makes sense because when bacteria are exposed to antibiotics, the antibiotics will kill off only those bacteria that are susceptible to the antibiotic, leaving those that are resistant to then grow and take over and then pass on their resistance genes from one bacterial strain to another. And we also know, and we've known for a long time, that when antibiotic use in a population decreases, so a population being a hospital unit or a community, resistance to that antibiotic subsequently decreases. And so we all know that antibiotics are life-saving drugs. We've all witnessed antibiotics save lives of patients that we take care of in this hospital. And so the idea of stewardship, that term stewardship in its broadest sense, refers to our collective responsibility to preserve a valuable resource. And antibiotics are a valuable resource that we need to keep working. We need to preserve them because we need to keep them working in order for them to continue to be life-saving drugs. And so the term antimicrobial stewardship refers to a multifaceted initiative that works to optimize the selection of a drug, the dosage of a drug, the route, and duration to result in the best possible clinical outcome for that individual patient while minimizing subsequent resistance, both in the bacteria that that individual patient is been colonized with, but also resistance for the population as a whole. So let's do another poll everywhere question. Antimicrobial stewardship programs, or ASPs, have been shown to reduce inappropriate antibiotic use, reduce time to cure, reduce C. diff rate, reduce antibiotic resistance, reduce length of stay, reduce cost, or all of the above. So you're all great test takers. So all of the above. So antimicrobial stewardship programs not only have been shown to decrease inappropriate use of antibiotics and hospital costs, but also improve clinical outcomes. And it's these benefits of antimicrobial stewardship programs that have led to ASPs becoming standard of care and are now a regulatory requirement from regulatory bodies, including the Joint Commission and Center for Medicaid Services. And the robustness of an antimicrobial stewardship program is also taken into consideration when looking at the quality of care that hospitals provide their patients by U.S. News World Report and other hospital surveys. So how are we doing at Children's National as an institution in terms of antibiotic use? So this figure is data from Pediatric Health Information System, or PHIS, which is a database of 47 freestanding children's hospitals, including our own. And the metric most commonly used for measuring antibiotic use is antibiotic days of therapy per 1,000 patient days. So it's standardized by patient days and standardized by hospital volume. And in this figure that displays the variability of antibiotic use by individual children's hospitals, you can see that our hospital right here is in the far left in the blue. So compared to our peer children's hospitals, we're a relatively high user of antibiotics. And while this is really just quantitative data and doesn't look at appropriateness of antibiotics, we are being compared by peer hospitals. So these in red are Seattle Children's Hospital of Philadelphia, Cincinnati Children's, and Colorado Children's. So other top-tier, high-acuity children's hospitals with fairly similar patient population to ours. And when you look more specifically at individual drugs, specifically the broad-spectrum antibiotics, you can see that across the board, we're using more antibiotics compared to our peer hospitals, and that pattern is really most striking for the broadest spectrum antibiotics. So for the carbapenems, meropenem or imipenem, we're using twice as much compared to our peer hospitals, and for ertapenem, we're using 10 times as much compared to our peer hospitals. So these are really our last-line antibiotics, the broadest spectrum that we try to preserve for those multi-drug resistant organisms when nothing else works or nothing else is possible to use. So So what are we doing about it, and what do we plan to do about it? So antimicrobial stewardship program or practices has been in place at our institution for several years now, but now we're a fully supported program with new faces. So led by myself and Dr. Benjamin Hammer from Pharmacy Department, our infectious disease clinical pharmacy specialist. We are the antimicrobial stewardship team, and the purpose of our program is to be a resource to all children's national clinicians to help optimize antimicrobial use in your patients. And we do that by, in addition to education, so education to physicians at all levels of training, nurses and other medical staff, and to patients, we also do that by promoting institutional guidelines, and by providing feedback to primary teams about patient-specific antibiotic use, as well as by requiring prior authorization for select antimicrobials. So a couple months ago, we sent out a survey to children's national clinicians to ask about perspectives and preferences relating to antimicrobial stewardship. There were 212 respondents to the survey, so thank you very much to those of you who completed the survey. About 65% were attending, so fairly well distributed across departments. And one of the questions we asked about was the use of guidelines. And the majority of respondents found that institutional guidelines could be used to help improve our antibiotic use at our hospital. So to help guide the empiric choices for select infectious conditions. And so one of the goals of our stewardship program is to work with individual stakeholders in different departments to develop new institutional guidelines to help guide empiric antibiotic choices where a gap exists, and also to help review and revise existing guidelines to make sure that they are up to date with the current evidence and literature, up to date with the national consensus guidelines, and also up to date with our local susceptibility patterns. So I just wanted to point out that our institution, like all institutions, has what's called an antibiogram. So we tabulate from all the culture data from within our hospital the susceptibilities of various different bacteria with different antibiotics, and those data are updated on a yearly basis. Dr. Joe Campos from the microbiology lab is working on updating the current data so that we have a 2016 antibiogram. I just want to point out so everyone's aware where to find it. It's actually embedded within PowerChart. You could just go straight to links, and there is antibiogram. And there's also has its own little button at that top right corner embedded within PowerChart. And this could be a valuable resource to help guide empiric antibiotic choices for various different conditions. In the survey, we also asked about preferences for different types of approaches of antimicrobial stewardship programs. So different institutions may take different approaches, and some institutions may rely more heavily on requiring prior authorization for select antimicrobials, while other institutions may rely more heavily on what's called prospective audit and feedback, whereby the antimicrobial stewardship team reviews antibiotic use and provides feedback to the teams. And at our institution, most respondents were more in favor of the audit and feedback. So that will be the focus of our program. So the antimicrobial stewardship team will be reviewing antibiotic use on a daily basis, and if there are any opportunities identified to optimize use, whether that be de-escalating, narrowing therapy, might even be broadening therapy, optimizing the dose, then we will communicate with the primary team in the form of verbal communication, as well as a note in the chart. And while it won't be the focus of our program, there will be a few select antibiotics, so some high-cost, high-toxicity drugs that will require prior approval from the Antimicrobial Stewardship Program before they will be dispensed by pharmacy. And we're still working on the IT implementation of this to ensure that appropriate safety mechanisms are in place. So as we get closer to the expected rollout, we'll be communicating institution-wide with the specific details of how this will be implemented. And we also want to encourage everybody, all clinicians, to take what's called an antibiotic timeout. So I don't mean that kind of timeout. What I mean is that, so frequently a diagnosis might not be certain at a time, but some infection is on the differential diagnosis, and cultures are obtained, and broad-spectrum antimicrobials are initiated, and that's perfectly appropriate. And we want there to be a prompted reassessment about 48 hours after antibiotics are initiated universally to stop and take an antibiotic timeout and ask yourselves, ask the team, are antibiotics necessary for this? Is the patient responding to antibiotics? If so, is this the right drug? Is it the right dose? Is it the right frequency? Is it the right route? And if you have all the data that you need to establish a duration, then go ahead and establish a duration, put in a stop date into Cerner, and we would recommend using the shortest effective duration. And if there's any questions about the best way to proceed, then we would encourage you to reach out to either the Infectious Disease Consultation Service or the Antimicrobial Stewardship Program, because our program's ultimate goal is to be a resource to all children's national clinicians to help optimize antimicrobial use in your patients. So with that, I'm going to hand off to my colleague, Dr. Harik, who is going to put it all together.
Thank you. Thank you so much. All right, so we started our presentation today talking about a case really to demonstrate that we do see children here at our institution that have resistant infections, and then we discussed ways to prevent those infections, prevent the development and the spread of those infections in particular. However, the case that we reviewed today was a case with a patient that had multiple chronic medical problems and also had multiple hospitalizations. And we know those things in particular put children at risk for having an infection with a highly resistant bacteria. So I'd like to end today, kind of tie everything together using a different case example, talk about maybe a more common infection that we all see in kids with and without chronic medical problems, and that's urinary tract infections due to Enterobacteriaceae. So those include organisms like E. coli, Klebsiella, Proteus in particular. So we'll start off with another poll everywhere question. So here you go. So worldwide, how many pediatric urinary tract infections do you think that we see due to extended spectrum beta-lactamase producing, those are called ESBL producing, so I'll use that for short from now on, Enterobacteriaceae. So do you think it's 1 out of every 2 urinary tract infections that we see worldwide are due to those resistant organisms? Is it 1 out of every 7, 24, 313, or 1 out of every 1,006? What do you guys think? I'll give you a few minutes to answer. I was going to say, I'm glad no one thinks 1 out of 2, but no, that's fine. Yeah, one day it will be if we don't do all of this, right? This is why we're giving this talk. One day we'll be there. We don't want to be there. Okay, great. So most people think 1 out of 24 or 1 out of 313. Actually, the best answer that we currently have based on the literature is 1 out of 7. So 1 out of 7. So this is based on a recent review that was published that looked at 16 studies with data for a total of over 7,000 cases of pediatric urinary tract infections around the world from 1996 to 2004 due to ESBL-producing Enterobacteriaceae. And based on those studies, they estimated that the worldwide prevalence of infection due to those specific resistant organisms was 14%, or 1 out of every 7, with an increase noted over that time period in the prevalence to end at where we are today. They included in their study both hospital-associated and community-associated UTIs. So this isn't just patients that are in the hospital that have chronic medical problems that have been on loss of antibiotics that are at risk for having highly resistant organisms. These are kids coming in from the community as well that have maybe never even been on antibiotics before, but because of increasing rates of asymptomatic carriage in our community are coming in with resistant organisms. When they looked specifically at just those urinary tract infections that were community associated, they found a prevalence of 5%. Now, I put this chart on here to show you that the prevalence actually varied a lot based on the location, and you can see that areas that had the highest prevalence are areas that really have limited infection control and antimicrobial stewardship programs. Although we had the lowest prevalence here in the Americas, where we have a lot of those resources available to us, I would remind you that here at Children's National, we take care of children that come from all over the world, and so we see many children who come from these areas as well. So, you know, I don't think we should look at this and say we should be really proud at just being at 2%, and particularly for our institution, our rates may be higher because of the patient population that we serve. In addition, I wanted to show you guys this study, which is a trend on just the prevalence in general of ESBL-producing Enterobacteriaceae in children. This is among isolates in U.S. hospitals from 1999 to 2011. These are isolates from everywhere. Urine was the most predominant isolate, but also from blood, respiratory samples, and also from wounds. And you can see that there was a significant increase in prevalence over time of ESBL-producing Enterobacteriaceae. And this particular graph shows this divided up by ICU patients, inpatients, and also outpatients. All of these were significant over the time period listed below. So why are these urinary tract infections due to ESBL-producing Enterobacteriaceae so important? Why am I talking about them today? Well, there have been many, many studies, both in the pediatric and the adult literature, that have shown us that individuals who have these infections have a longer hospital stay, on average 1 to 1.5 times higher than individuals who have a urinary tract infection that's due to a non-ESBL Enterobacteriaceae species. In addition, the median cost of care is much higher among those patients, and in terms of bottom line for our dollar, the median cost of care is not actually reimbursed, so it leads to a loss of revenue. So looking at adult studies, they've monitored this closely, and the additional cost is not offset by reimbursement. So there is a significant loss of money to the institution as well. So Dr. Song and Dr. Hamdy already spoke to you about ways to prevent the spread of resistant organisms, both through infection prevention and antimicrobial stewardship. And I'd like to show you 2 exact examples related to ESBL Enterobacteriaceae that we're talking about today, where infection control and antimicrobial stewardship have really made a difference in reducing rates of ESBL-producing Enterobacteriaceae. So the first example is an example from infection prevention. This is a group that modeled an outbreak that was caused by one person that had an ESBL-producing Enterobacteriaceae admitted to a 10-unit hospital bed unit. And when this group modeled hand hygiene, so the simple thing we talked about, washing our hands, initially compliance, and improved it in their model from 60% to 80%, both before and after patient contact, so they improved it from 60% to 80%. The incidence of ESBL-producing Enterobacteriaceae colonization was reduced 91% in their model. So washing your hands makes a difference. We've seen that with data from our own institution as well that we showed you today. It makes a difference with ESBL-producing Enterobacteriaceae as well. Infection prevention can help to protect our patients. The second example is from the ASP world, antimicrobial stewardship. This is a study from Denmark. It was actually done in adults. In an adult hospital, where in a university hospital there, they applied stringent guidelines for antimicrobial stewardship, more stringent than what we're talking about today. They actually restricted ciprofloxacin and fluoroquinolone and cephalosporin usage. You had to call infectious diseases and get permission to use any of those antibiotics in their hospital. They also implemented an education program, both on infection prevention and antimicrobial stewardship. And after beginning that intervention, which is indicated here in the arrow, you can see that their rates of infections due to ESBL-producing Klebsiella pneumoniae was reduced significantly. So again, antimicrobial stewardship can also help to protect our patients with this situation. I added this slide to our presentation actually just a few days ago. This is a case report here, and then a subsequent news story. So you can see this was out there in the news that was just actually posted on January 13th about a woman in Nevada who died in August of 2016 due to septic shock due to a highly resistant strain of Klebsiella pneumoniae. It was resistant to 26 different antibiotics. All the antibiotics available to use to treat her here in the United States, available to us in the United States, she was resistant to, and she died due to her infection. So again, a reminder that these resistant bacteria are out there. We don't want them in our patients. We don't want them in our hospital. They're there. So I'd like to end today by just saying that in 2017, I hope we can all resolve to protect our patients both now and in the future by focusing on basics of infection prevention and on advancing antimicrobial stewardship in our institutions. Thank you very much.
Yeah, I really wanted to make this a bit interactive because I think we have a lot to learn. So can I have our presenters come up? And I just want to make a few comments. Thank you, Rana and Ben, for listening to us. You did a survey, and I remember we all participated in that survey, and you actually listened to the feedback. Thank you. I think it's frustrating when we do surveys and you just do what you want. We have one of the lowest CLABSI rates in the country. I want to say that again. Children's National has one of the lowest CLABSI rates in the country, and I think now you know why. It's really the work that this team does for vigilance. It's pretty impressive. So I want to just start with a question, and then we'll open it up to others. Rachel will pass that around. So I will preface this by saying I'm a surgeon. So, you know, I give amoxicillin, Keflex, clindamycin. After that, they don't need antibiotics. So you said less antibiotics actually reduce the infection burden, right? You showed that study from Lancet. Can you talk a little bit about that? When you give less antibiotics, it reduces the resistance, right? Am I saying that right?
Yeah.
Speak to a surgeon.
Sure.
Can you use the microphone?
So it has been shown time and time again in multiple peer-reviewed studies. That 1970 study from the Lancet was really the first of many to follow. That overall, when antibiotic use in a population, overall, so sort of like epidemiologically looking at communities, when antibiotic use declines, resistance to that antibiotic use declines, which makes complete sense based on what we know about bacteria and antibiotics and how they work. And so we're not suggesting that we not use an antibiotic when it's needed. We're suggesting what we need to do is use the narrowest spectrum antibiotic that's necessary and that is effective to treat that patient, because the broader spectrum antibiotics, then you're going to get those resistant organisms to that broad spectrum antibiotic. And also use the shortest duration that's necessary, that's effectively necessary to treat that patient, and not use them when we don't need them. So don't use them for viral infections, don't use them for colonization.
So I hear you, but I'm just going to consult for infectious disease.
Yes.
No, I'm kidding. Thank you. Questions from our house staff or from others? Sophie?
Thank you. This was very informative. I'm an anesthesiologist, and I have a question that relates more to patient and family experience, and in regards to MRSA. So I get to the preoperative area, and I have a family that comes in for surgery and is appalled because we're starting to put on yellow gowns, and tells us that they have been, the last time they were here was years ago, and yet they're in the community, and it still says that they're MRSA positive in their chart. And I know there's a process, and there's nasal swabs that have to be done, et cetera, but is there a point person or a system that's really in place that checks these charts and perhaps at their clinic visit or a system in place to really take care of this and clear them?
Yep. This is a fantastic question, because this is really one of the two pieces infection control right now is working on day in, day out. Ever since we have this great team all on board, that was October, because finally we have the manpower to go through MRSA. The reason we have started with MRSA, it's 10-year and more than 10-year worth of accumulation of patients in our chart. And to be honest, at this point, from CDC, those national guidelines, there's no clear definition on what time we can discontinue isolation because patient has a history of MRSA. That's still a question very much studyable, and nothing has been published. So based upon our experience, based upon the literature review we have done, based on consulting other hospitals, the top hospitals, we started coming up a protocol, basically discontinuation protocol that we tried inpatient units in certain areas first, and now it's brought into all inpatient units. We started the trial in October, and now it's actually this inpatient unit-wide review is done every day by infection prevention. And so we have certain criteria. So if the patient meets the criteria, we'll start calling the team and say, hey, is it possible to consider discontinue the isolation? So all this being said is the process already started. So it's going to take us some time to clear the system. But we still want to emphasize if a patient comes in with symptoms, the wound draining and the wounds, the still open wounds, those patients still need to be on isolation.
Sure. I'm just mostly referring to the outpatient.
Yeah, because I think what happens is we get a fatigue. You know, we see yellow gowns, and that lowers our sensitivity. Do you, if I can just push you, I mean, we're colleagues, what is the timeline for rolling to the operating room to outpatient, and how long does the protocol say that a child has to be negative before you'll discontinue that status? And thirdly, is it not then we're removing the flag and Cerner as well?
So I can say like the protocol we're using right now, if a patient has 10 years ago within our NICU with the swab positive for MRSA, ever since never come back to the hospital, we're very much going to remove this isolation flag in the system. And if a patient has a little more recent visit, there seems to be a predominant source, and the patient being rehospitalized, at that point we may have a chance to re-swab the patient just to be sure the patient truly no longer carries the organism. If it's the one swab come back next, we're going to DC this isolation in the system. For our patients, since our OR is really serving both inpatient and outpatient basis, I do know you do the chart review before patients come up. So what I would say is that when you do the chart review, and feel free to write email to infection control or to me, just let us just take a look before patient come in. We'll be happy to assess that.
I think it's a great happy medium. Would you agree, Rich and Sophie?
Very, very helpful.
I think so too, yeah. I appreciate that. And I see it's a work in evolution, so that's a great question. That's it from the operating room. Mary, this might be our last question, if that's okay.
I hate to ask this question, but if we're taking care of all these patients and we're checking them, should we be checked at some point?
So have you swapped our phones? Have you all done anything?
We swap our phones, and we actually have a very unique tool. And anyone who actually wants to try the phone, I'm happy to help you right after Grand Round. Come to our suite. We can swap your phone just to tell you if your phone is actually loaded with something or just really super clean. We actually have a tool can tell us almost in 10 seconds. Yes.
Have you thought about maybe just rolling that out spontaneously one day on the ward? I'm just curious. I mean, you bring it up. I'd love to see. Is that something, or that's not scalable?
It's a scalable in the sense we can do it. It's quite expensive to pay for the Dr. Campus knows, but without a cost. But it's really every single place that we have taken this tool in, it's just very wow. I wanted to wipe off this and that. So it is.
Right, exactly.
It can very much.
Right, the hand washing, I think, is the key there. So we should assume that many of us are carrying resistant organisms. And the key is good hand hygiene practices, and then sticking with if we're on contact isolation, sticking to those standards as well.
Yeah.
So that's going to be our key as healthcare providers.
Mm-hmm.
Well, I do want to thank you very much to you five for the great work that you're doing, and thank you all for the audience. Thank you.